13th edition Chengai Pediatric Meet, that is the Chengalpet branch of Indian Academy of Pediatrics. At the outset, I would like to thank the organizers for giving our college this opportunity to host this hybrid model. And I also would like to congratulate Dr. Subhash HOD SRM and Dr. Balaji, who have been very vibrant and continuing this into the second year. Congratulations to SRM team. Now, today's we are having 3 cases, one from the Balaji Medical College, one from Chettinad Medical College, and another from Kamakshi Memorial Hospital. Without much delay, I would welcome the first speaker, Dr. Smita Merlin, who is a final year postgraduate of Balaji Medical College, to talk on triple bubble, what's the trouble? And the moderator of the session will be Professor Dr. Jagdishwari, the professor of Department of Pediatrics. Thank you.
Thank you, ma'am. The title of my presentation is Triple Bubble, What's the Trouble? A 3-hour-old male neonate, informant being the mother with good reliability, presented with chief complaints of upper abdomen distension and greenish color vomiting. History of presenting illness. A 3-hour-old male neonate, informant mother with good reliability, presented with chief complaints of upper abdomen distension, feeding difficulty, and greenish color vomiting. History of presenting illness. Baby was feeding well initially, but after feed, mother noticed distension in the upper abdomen, which was progressively increasing after every feed. There was history of 3 greenish color vomiting. Baby did not pass meconium since birth. Antenatal history, married for 1 year, it is a primary mother with spontaneous conception, confirmed by UPT at 60 days of amenorrhea, booked an immunized case with regular antenatal visits.
Madam, your slides are not moving. Slides are not moving. Please check it.
Slides not. Pre-pregnancy weight was 65 kgs and weight gain during the pregnancy was 9 kgs. All the 3 trimesters was found to be uneventful. All the antenatal scans was found to be normal. Natal history.
So 1 minute. Ma, stop pannu. Stop.
Now visible, doctor. You can start. Hello, doctor. Dr. Smita. You're muted, doctor.
Yeah.
Can you hear, sir?
Sir,
Yeah,
it's
now,
audible now?
yeah, now your audio is on. Now video is also on. Yeah.
All the 3 trimesters was found to be uneventful. All the antenatal scans were found to be normal. Natal history, it is a full-term normal vaginal delivery with birth weight of 2.3 kgs. Baby cried at birth, like was clear. Postnatal history, baby passed urine after birth. Meconium was not passed. Breastfeeding was initiated at 1 hour of delivery. Baby was admitted in NICU due to abdomen distension and bilious vomiting. Slides not moving. Slides not. Family history, non-consanguineous marriage, married for 1 year. No history of any hereditary disease or major illness running in the family. On examination, baby was sleeping comfortably in universal flexion position. Cry, tone, and activity of the baby was good. Color pink and normothermic. I present from my eye. Vitals, temperature was 36.6 degrees Celsius, heart rate 138 per minute, regular in rhythm. Respiratory rate was 46 per minute, and saturation was 98% at room air. Anthropometry, birth weight was 2.3 kgs, and the length of the baby was 50 centimeters, head circumference 35 centimeters, and chest circumference 34 centimeters.
Nisha.
You're muted, doctor.
Head-to-toe examination, scalp, hair normal, no sutural diastasis, no swelling over the scalp. Head shape is normal, anterior fontanelle open at level, measuring 2 into 2 centimeters. Posterior fontanelle admits tip of the little finger. Face, no facial dysmorphism. Eyes normal, pupils bilateral reacting to light, no discharge or no redness. Ear normal in size, shape and position. Nose normal, oral cavity normal, no cleft lip or no cleft palate. No neck swelling, chest bud more than 5 millimeter on both sides, areola well formed, external genitalia normal, limb and spine normal. Systemic examination, per abdomen, generalized distension was present. Soft umbilical stump intact, no organomegaly, hernial orifices are free, bowel sounds present, no visible bowel loops or no visible peristalsis. Respiratory system, bilateral air entry present, equal on both sides. Chest movement bilaterally symmetrical, no added sounds, no retraction. CVS S1, S2 present, no murmur. Central nervous system, tone was normal, anterior fontanelle at level. Neonatal reflexes, rooting, sucking, oral reflex present. Hammer and plantar grasp was present. Asymmetric tonic neck reflex present. Spine and cranium was normal. Diagnosis. Differential diagnosis are duodenal atresia or stenosis, midgut volvulus, interstitial atresia or stenosis. Diagnostic test. CBC was found to be normal. No evidence of any electrolytes imbalance. Abdominal X-ray shows triple bubble signs suggestive of jejunal atresia. A diagnosis of neonatal jejunal atresia was made based on the clinical presentation and diagnostic workup. This is the X-ray of the baby showing triple bubble sign. Confirmatory diagnosis was made based on the history, physical examination, and the radiological finding. Management. NG tube was passed to decompress the abdomen and approximately 30 ml of bile fluid was aspirated. Pediatric surgeon consultation was obtained. Baby was posted for laparotomy and resection of ectatic segment, tapering jejunoplasty with jejunoileal anastomosis was done. Surgical findings. Proximal grossly dilated jejunal loops with blind ending segment with 90-degree torsion was noted. Atretic segment was located 60 cm from the duodenojejunal flexure. 7 cm of ectatic bowel segment was resected. End-to-end jejunoileal anastomosis was done. Mesenteric rent was closed. Hemostasis was secured. Glove drain was placed and wound closed in layers. Post-operative period, child was treated with IV antibiotics. Contrast study was done on post-operative day 6. Contrast stasis in ectatic segment and distal flow was noted up to the rectum. Child was started on tube feeds gradually, then to infusion feeds, then on Paladay feeds. Now child tolerating direct feeds and passing stools normally. On follow-up, baby was feeding well and weight gain was appropriate. No other complaints. Discussion. Interstitial atresia is a broad term used to describe a complete blockage anywhere in the intestine. These conditions may involve any portion of the gastrointestinal tract. The small bowel is the most commonly affected portion. Jejunoileal atresia involves an obstruction of the jejunum or ileum of the small intestine. The segment of the intestine just before the obstruction becomes massively dilated, thus hindering its ability to absorb nutrients and peristalsis through the digestive tract. In 10 to 15% of infants with jejunoileal atresia, part of the intestine is necrosed during the fetal development. A significant percentage of infants with this condition also has abnormalities of intestinal rotation and fixation. Types of jejunal atresia, there are totally 5 types. Type 1, a mucosal web occludes the lumen, but the continuity is maintained between the proximal and the distal bowel. In type 2, involves a small diameter solid cord that connects the proximal and the distal bowel. Type 3 is further subdivided into 2 types. Type 3A occurs when both ends of the bowel end in blind loops, accompanied by a small mesenteric defect. Type 3B is similar, but it is associated with an extensive mesenteric defect and loss of the normal blood supply to the distal bowel. The distal ileum coils around the ileocolic artery, from which it derives its entire blood supply, producing an apple peel appearance. This type is mostly common in premature infants. Type 4 involves multiple intestinal atresia. In rare cases, type 4 atresia may be associated with pathogenic variants in the TTC7A gene, which disrupts normal development of the thymus and the intestinal epithelial lining of the intestine. This subset of patients may present with stricturing inflammatory bowel disease, severe combined immune deficiency, and associated recurrent sepsis. Hence, type 4 atresia uniquely warrants genetic and immunologic screening. Clinical manifestation. Polyhydramnios is the first sign seen in utero. It is present in 20 to 35% of the infants. Abdominal distension is rarely present at birth. It increases after initiation of feeds in the first 12 to 24 hours. Abdominal distension is mostly associated with bilious vomiting. 80% of the infants fail to pass meconium in the first 24 hours of life. Jaundice is seen in 20 to 30% of the infants. Treatment. Documented infection should be treated with appropriate antibiotics. Prophylactic antibiotics are usually given before surgery. Jejunal atresia requires resection of the atretic portion of the bowel followed by an end-to-end anastomosis. If a simple mucosal diaphragm is present, jejunoplasty or ileoplasty with partial resection of the web can be done. Operative management is indicated when the obstruction cannot be relieved by repeated attempts at non-operative management and for infants with complicated meconium ileus. Thank you.
Now the case is open for discussion. Questions are invited.
It's a good presentation from Balaji Medical College. Nice presentation.
If there are no questions, then I invite Professor Jagdishwari to give her comments about this case.
This is a 3-year-old baby had vomiting meconium. So when we aspirated the stomach content, it was meconium stain. We should not mistake this for meconium stain liquor and fetal distress, because as we aspirated the stomach content, the daily mucus extractor was full and it also continued to come from the stomach. So the aspirate is exceeding the mucus extractor, that is more than 30 ml, we should suspect some bowel upper GI obstruction. That is why we thought it is only upper GI obstruction and the baby did not have any respiratory distress. So we immediately took an X-ray and it showed 3 bubble. Why we presented is, we all are familiar with the double bubble. We are not familiar with the 3 bubble. So we thought it is not duodenal atresia, and mostly duodenal atresia is combined with some congenital anomalies. This baby never had any other anomaly except the intestinal atresia. So we immediately called the surgeon and this baby was lucky to have the surgery done immediately without any postponement, and child recovered very well. And now the child is coming for vaccination, but there is a little failure to thrive because this child is having lost some part of the intestine, so showing some obstruction, deficiency of vitamins. So we are supplementing iron and vitamins, spite of it having failure to thrive. Child had anemia and that was corrected. So now the child is doing well. This case was presented mainly for the rarity. Thank you for the opportunity. Any other questions?
How long was the baby kept nil for oral? Am I audible?
Question.
This baby was on NPO nearly for 4 days. And subsequently, this child received IV fluids and breastfeeding started. After the dye injection and it passed up to the rectum, they started the IV oral feeds. Initially with tube feeds, followed by pallida feeds. This child was in the hospital for nearly 15 days following surgery and then discharged.
Whenever a child presents with any intestinal atresia, we must also rule out syndromes and also the associated anomalies of the genitourinary tract, brain and cardiac defects. But luckily, this child did not have any syndrome or did not have any associated anomalies. Thank you.
That was a good presentation, ma'am.
Thank you.
Yeah. Ma'am, in follow up, ma'am, what else planned, ma'am?
Baby is doing well.
Ma'am, we are unable to hear, ma'am.
This baby has completed 6 months and this baby had failure to thrive, anemia that was corrected. Still the child is having not catching up the weight. Child received correction of anemia with 1 blood transfusion. Now the child is on all vitamin supplementation. Complementary feeding started. So doing well, but weight is around only 5 to 5 kg or so. The issue is mainly failure to thrive. Otherwise, baby is doing well. General condition is all right.
We go on to the next case of cutaneous, a series of cases of cutaneous larva migrans in children. Is it as rare as we think? By Dr. Sampath Kumarasamy, and the moderator is Dr. Sunita Ramasamy, who's from Chettinad Hospital and Research Institute. So continue to present the case.
Good afternoon to everyone present here. Myself Sampath, postgraduate from Chettinad Hospital.
Sambat, click on that enable editing option on the top. There is a yellow bar coming up, right? Can you hear me, Sambat?
Yes, sir.
Click on that enable editing bar on the top.
Yes, sir.
Yes,
Sir, we are sharing the slides. Now, somebody share the slide. So we are sharing the slide.
Sambat, what happened?
Yes, 1 minute, sir.
No, I think the host is sharing.
Yes.
So we are not able
Sir,
to.
we are sharing the slides.
Okay.
Are the
They are
slides
sharing it.
I'm changing the
I think
slides.
you can share
please
from
check?
your end, Dr. Sambat.
Yes, sir. I will share, sir. For that, they want to make me host, sir.
Okay, you share. We are
Uh,
stopping.
No
Can you
need
make
to,
the host?
actually, no need to be host. You can share, Doctor.
Hold on 1 second.
Dr. Sampath, you can share and present.
Yes, I will share, sir.
Are the slides visible?
Yeah, put it in slideshow mode.
Yeah, we have
Yes.
made the slides visible.
Yes, right.
My topic is cutaneous larva migrants in children. Is it as rare as we think? A series of cases after Chennai rains. First case, 6-month-old infant came with complaints of a raised thread-like tract in right gluteal region for 7 days. Mother confirmed that the tract was growing each day, associated with irritability with sleep. He hailed from low socioeconomic background. On examination, a serpineous tract was noted on his gluteal region. This was the first case. Next case, 5-month-old infant came with the complaints of serpineous palpable lesion for 7 days, hailing in a nearby coastal village. Mother gave a history that several dogs and cats inhabit their muddy house. On examination, there was a small serpineous tract was noted on her back. Third case, 8-month-old infant brought by mother with the complaints of worm-like tract in buttock for 10 days. Daily, there is a gradual increase in size of the tract from one end. Family hailed from a low socioeconomic background with a history of stray and pet dogs present around their gacha house. On examination, there was a serpineous tract was noted on her gluteal region. Another next case, 18-month-old infant came with the complaints of a snake-like tract in the right dorsal foot for 7 days. Family hailed from low socioeconomic background, living with farm and pet animals. On examination, there was a serpineous tract was noted at the dorsal aspect of the right foot. Next case, a 3-year-old male presented with the complaints of persistent itchy erythematous tract in the ankle for past 15 days. History of rearing pets at home with a barefoot walking at the farmhouse. They are also hailed from low socioeconomic background. On examination, there's a multiple erythematous serpineous tract was noted at the left ankle and heel. Another child with 6-month-old infant present with the complaints of snake-like lesions in buttock for past 12 days, with increase in lesion from one end. History of pet dogs and cats present inside their house. On examination, a right thread-like lesion on buttock with 6 centimeter in length was present. Another case, 2-year-old male child present to us with an intensely itchy lesion over dorsum of foot for past 15 days. Mother gave history of child playing in muddy soil. For similar illness, home remedies were taken. On examination, a 8 centimeter thread-like lesion present over the dorsal aspect of right foot. Next child, 3.5-year-old girl child, referred from PHC for evaluation. Erythematous circular pruritic continuous cutaneous lesion over right finger for past 7 days. Child was treated outside with cefalexin for past 2 days. In spite of giving antibiotics, mother gave history of gradual increase in size. On examination, a curvilinear palpable thread-like lesion present over left ring finger. Another case, 4-year-old male child present to us itchy lesion over lateral aspect of chest for past 1 week. Gave history of child playing in the soil. On cutaneous examination, a curvilinear palpable tract of 7 centimeter present over lateral aspect of the chest. Next child, 2-3-month-old child came to the OPD with the complaints of multiple papillary erythematous eruption noted over abdomen and left thigh for past 6 days, associated with itching and disturbed sleep. For similar complaints, child was treated out with anti-itch lotion. On examination, multiple papillary with serpineous lesion present over the abdomen and left thigh. We done investigation for all these child. CBC then showed only eosinophilia for 3 child. Treatment for all cases we treated with tablet albendazole 400 mg per OD for 5 days. Out of which 5 cases they came for follow-up and a complete dissolution was seen. This is the first case. Before treatment and after treatment. Sharing the pictures of these are the sharing the pictures of follow-up cases. This second case, before treatment and after treatment. This third case, this is before treatment. This is after treatment. This is before treatment and after treatment. The last case, this is before treatment and after treatment. Cutaneous migrans is caused by invasion and migration of parasitic larvae worms, which cause cutaneous dermatitis. Most common cause are Ankylostoma caninum and Nectar americanus. It's a zoonotic disease primarily found in dogs and cats. They are the definitive host. Humans are the accidental host here. Following passage in the feces animal, eggs hatch in the warm and humid environment, after which nematode larvae remain viable for 2 months. That larvae makes direct contact with the skin of human and penetrate inside. Their invasion will limited to the epidermis. It is due to the lack of collagenase, which have the capability to breach the epidermis. Consequently, they will wander in the epidermis and producing serpiginous tract. Most common sites are feet, hand, buttock, and lower abdomen. Primary presentation include a raised erythematous serpiginous tract, occasionally forms bulla. Grow at a rate of 2 to 3 centimeters per day. They are associated with intense pruritus for 10 days after larva penetration, and they will have irritability and interfering with sleep. Diagnosis often they are clinically based on appearance. CBC can be used for secondary infection or to see eosinophilia, and they will have a high serum IgE. Treatment, albendazole, anyone we can use. Albendazole 400 mg per hour for 3 days, or ivermectin 200 mg per kg for 1 to 2 days, and a topical thiopentazole along with antihistamines can be used. Preventive measures include personal hygiene, promoting constant use of slippers or shoes, and implementing deworming programs of pets. These are my references. Thank you.
Now I invite Dr. Sunita Ramasamy to give her comments, and the case is open for discussion.
Good afternoon, one and all. Why we brought out this presentation is it's not that rare to see a cutaneous larva migrants, especially after rain and those living in the coastal areas. And one more thing is it's not, we have a few of a typical presentations of cutaneous larva migrants where we had the serpiginous tract, and there can also be atypical presentations where you can have a maculopapular rash, or it could also present with folliculitis, especially if it is involving the region. The gluteal hair folliculitis can happen. Can also present like a migrating urticaria. So it should not be misdiagnosed or underdiagnosed. So the treatment is very simple. When you just deworm the child, it is going to be the treatment. That is why we just wanted to highlight the case, especially those living in coastal areas with a poor socioeconomic status. So this is very common in these areas. And the prevention is very easy actually. When you regularly deworm your stray dogs, domestic dogs or cats, pets in your home. And also health education is essential in these people. Any other queries or doubts?
I just wanted to add up few more points onto that. And as we said that it is occurring every time after Chennai rains. So all these cases of around 10 cases, I hope he has presented. All these cases, even though it has been like spread over this last 7 to 8 years, in that most of the cases clustered around in and after the Chennai rains. So after this 2015 Chennai rains, we see some number of cases, around 3 to 5 cases in the same week we have seen. And again, after the last year rains, we have seen. So the clustering of cases generally occurs after massive rains. Maybe it is because of that the worms might be easily, they are getting migrated and they can able to reach. The other unusual thing is that infants here are very commonly affected. If you would have seen, most of these cases were infants, and the location generally we all think it will be occurring in the legs or foot. But here we can see in the gluteal region, we can see in the chest, we can see in the fingers. So all these were because these infants were made to lie on the floors. So after these rains, when there are no like a carpet or in a muddy soil, if you make this children lie down and put it, then automatically there is every chance that this infection can enter through any of this area. The thing is that even though it is not going to be very harmful, but it can cause a lot of alarms to the parents saying that something is going every day kind of thing. So treatment might be simple, but still yet this has to be prevented. We all know that a lot of children come with a worm infestation every day, they come to our clinic. So it has to be treated with a very rigorous deworming program. That's our point.
Any
Thank
other
you, sir.
questions?
Thank you, sir. Thank you, ma'am. Actually, the number of cases shown was good, sir, because we are not seeing so many here. So thank you for the presentation, actually.
I thank Dr. Sampath Kumar Sami for highlighting us the importance of this cutaneous larva migrants, which is so called. Actually, we are not aware that we don't see so many cases here because of this humid and tropical climate. I think these larvae, they survive in the soil for a long time, and then when the opportunity comes, they invade the skin, and this also stresses the importance of barefoot walking. So though it cannot be avoided in a rural setup, as far as possible, barefoot walking should be avoided. And apart from this hookworm infestation can stay, if it is a visceral hookworm infestation, it seems they can stay alive in the intestine for more than 5 years, causing chronic anemia, malnutrition, hyperproteinemia. So hence the importance of deworming. Thanks to the government of India for the biannual deworming day, by which we can catch so many children all over the India and prevent parasitic infestation. Thank you.
Thank you, madam.
Next case is foreign body in children, a challenging case by Dr. G. Vignesh, and the moderators are Dr. Savita, and also I would invite Dr. Kirti Vasan to give his expert comment.
Good afternoon, everyone. I'm Dr. Vignesh, first year pediatric resident, Dr. Kamakshi Memorial Hospital. Today, we are going to discuss a topic on foreign body ingestion in a child, a challenging case. First, let's see history. A 7 years female child was brought to the pediatric ER. One second. A 7 years female child was brought to the pediatric ER with alleged history of swallowing foreign body magnets, DIY magnets, before 30 minutes of arrival to the hospital. She also had history of throat irritation since swallowing. There is no history of breathlessness, nausea, vomiting, or abdominal pain. Birth history: she is a second-born child born out of third-degree consanguineous marriage. She is a term child born by normal vaginal delivery. Her birth weight was 2.9 kgs. She cried immediately after birth. Neonatal period uneventful. She attained milestones appropriate for age. School performance of the child was good. She was vaccinated up to age according to IAP schedule. General examination: on arrival, the child was alert, afebrile, rest other vitals normal. Anthropometry was appropriate for age. Systemic examination: in abdomen, the abdomen was soft, there is no abdominal distension, non-tender, no organomegaly, bowels on cert, rest other systems was normal. Then we proceeded the child with X-ray chest with abdomen erect. We could localize the multiple magnets in the stomach. As you can see, there is a multiple magnets in the stomach. In view of multiple magnets in the stomach, the child was kept on NPO. Pediatric gastroenterologist Dr. Kirti Vasan's opinion obtained. Child was taken up for emergency endoscopic foreign body removal. Parents informed that the child has taken food 5 hours back. So initial check endoscopy revealed stomach full of food residues. The child was immediately intubated for airway protection. Initial attempts to remove the multiple magnets failed due to poor vision. Food residues were cleared via Rothnet using multiple passes so as that magnets could be visualized. Magnets were then caught via Rothnet in a single attempt. Remaining food was diluted with normal saline and suctioned out so as to minimize the risk of post-procedure aspiration. This is the endoscopic image. As you can see, there is a food residues in the stomach. Then in second image, you can visualize the magnet was completely surrounded by food particles. This was a Rothnet, which was introduced via endoscopic port, which was first used to clear the food residues. Then multiple magnets were captured and removed. Post-procedure was uneventful. The child was initially started with clear liquids after 6 hours, and then she was tolerated soft solids. The child hemodynamically and clinically stable, and hence discharged on the next day. As you can see the timeline of events, at around 5 p.m., the child had a history of ingestion. At around 5:30 p.m., the parents took the child to Kamakshi Hospital, and at around 6 p.m., we shifted the child to OT. And around 7:30 p.m., endoscopic removal of multiple magnets done. The next day, the child was discharged with no complications. Next, we proceed with discussion. Foreign body ingestion in children can lead to life-threatening problems. Foreign body ingestion is common between age group of 6 months and 3 years of age. Most common foreign body ingested by child are coins, fishbone, button batteries. 98% of around it was accidental. 80% of the foreign objects are likely to pass without the need of intervention. Incidence of magnet ingestion is increasing presently, and it is associated with increased mortality and morbidity. Magnet ingestion, introduction of small real earth magnets in 2009, which resulted in a significant increase in incidence of magnet ingestion. Among the toys play a major source. Incidence of magnet ingestion is approximately 3 cases per 1 lakh people. Multiple magnet ingestion mostly occur in older children with a mean age of 7 years. There is an average annual increase in incidence of about 6.1% from 2009 to 2019. The earliest report of bowel perforation with ingestion of magnet was from Japan in 1995. Multiple magnets in pediatric patients has increased the risk of obstruction and perforation. 75% of the children with magnet ingestion were between 6 months and 5 years of age, according to American Association of Poison Control Center. Now, recently, the DOA magnets are into the market, which contains of ferromagnet metals made up of nickel, steel, iron. The neodymium magnet is one type, which is much more stronger than the traditional magnets. Extreme high risk of intestinal obstruction and perforation is with neodymium magnets. If more than one magnet is swallowed at the same time, or co-ingestion with other metallic objects can result in bowel damage. In the first image, you can see presence of one magnet in the stomach and the other in the intestine. Due to the strong magnetic force, which pulls the both magnets together, causing the stomach and the intestine to come closer, which results in pressure necrosis, ischemia, and perforation. Not only this, the magnetic forces can also impair the gut motility. In this image, you can see that there is a linear arrangement of magnets in a single loop of intestine, while in this image, you can see the presence of single magnet in each loop of intestine, causing the magnetic force pulling every loop of intestine to come closer and resulting in pressure necrosis and later ischemia and perforation. Neodymium ion boron magnets are 20 to 25 times more powerful and which are sold in sets. Even if these magnets are quickly removed from the gastric lumen with endoscopy within 8 hours, there can be features of ulceration and indentations of mucosa if there is delayed presentation of the child for more than 12 hours after ingestion, which can cause more complications. Usually, a child with a magnet ingestion can present to hospital with gagging, choking, drooling, vomiting, or abdominal pain, abdomen distension, or abdominal cramps. The signs of magnet ingestion can be abdominal distension, tenderness, ileus, and there can be sluggish bowel sounds. Usually, 2 investigations of X-ray are needed: X-ray chest with abdomen erect and lateral X-ray abdomen erect. Usually, in chest X-ray with abdomen erect, you can see the magnets, but if the magnets are attached anteroposteriorly, then it can be visualized only in the lateral X-ray abdomen. Then let's see the management. Based on the single magnet or double magnet, the management protocol will...
When I went only, they can come.
If the magnets are within the stomach or esophagus, first we should get a pediatric gastroenterologist opinion and we should consider removal, especially if at increased risk of further ingestion of other metallic substance or magnet. The follow-up with serial X-rays as OB basis should be done. The removal of any metallic magnetic objects nearby are some measures. Then avoid clothes with metallic buttons, belt with buckle should be done. And also we should ensure that no other metallic objects or magnets in the child environment for accidental further ingestion. If the single magnet is beyond the stomach, we should consider the removal only if accessible. And we should always obtain pediatric gastroenterologist consult follow up with serial X-rays as OPD basis as we done priorly. And if there, in case of delayed progression, we can use PEG solution to aid in the passage. Management of multiple magnets. If the multiple magnets is within the stomach or esophagus, then based on the hours of presentation from the child, the protocol varies. If the ingestion is less than 12 hours, we should call gastroenterologist for removal. If the ingestion is more than 12 hours, we should consult pediatric surgeon prior to the endoscopic removal. In case of successful removal, we can discharge the child, and we should follow up, and education should be done, which can prevent further ingestion of any other foreign body in the child. In case of unsuccessful removal, we should call pediatric surgeon for removal. If the foreign body magnet, multiple magnet is beyond the stomach, we should admit the child only if pediatric gastroenterologist and pediatric surgeon is available. You refer the child if both are not available. If the child is symptomatic, then refer the child to the pediatric surgeon for removal. If the child is asymptomatic, then we should see in X-ray, we should see whether any signs of obstruction or perforation. If there is no signs of obstruction or perforation, we can remove it by enteroscopy or colonoscopy. Consult pediatric surgeon prior to the removal. Serial X-rays should be done for progression. If in case of successful removal, we can discharge the child after orally tolerating. And as I said earlier, we can follow up and educate the child to prevent further foreign body ingestion. In case of unsuccessful endoscopic removal, refer the child to the pediatric surgeon. Then serial X-rays in ER should be taken 4 to 6 hours apart for progression. In case of no progression, we should admit the child in hospital, and we can use PEG solution to aid in passage. Serial X-rays every 8 to 12 hours should be taken. If no symptoms, we can proceed with surgical or endoscopic removal. If progression of magnets is there, we can educate the parents on precaution and discharge with close follow-up. We should always confirm the passage with serial X-rays. If at any time magnet do not progress, or if the child is symptomatic, we should admit the child removal. Complications. The most commonly seen complications are ulceration, necrosis, and around 2/3 or 3/4 cases of multiple magnet ingestion usually result in perforation. There can be also chances of stricture, fistula formation, gastric outlet or bowel obstruction, peritonitis, mediastinitis, volvulus, sepsis, sometimes even can lead to death of the child. Endoscopic removal should be performed under general anesthesia with a protected airway. A net retrieval devices, Roth net, is often used. Pediatric surgeon should be involved early in complicated cases, especially those with multiple magnet ingestion located distal to the stomach. Conclusion. Multiple magnet ingestion is associated with complications, mainly obstruction and perforation. The time interval between the ingestion, presentation, location of magnets, number of magnets determines the next step of management. Anticipation of complications and early referral is important. Prompt removal by upper GI endoscopy always limits complications. Multiple magnets in stomach seldom wait. Thank you.
I congratulate the Kamakshi Memorial Hospital team who have made great effort to remove the foreign body within 2 hours of arrival, even though the child was in full stomach. Now the case is open for discussion. I have a few more questions. Since foreign body ingestion is more common in younger child, this child is almost 6 years old. Did you go into the history of any pica? And did you rule out any iron deficiency, or did you supplement the child with iron and zinc? Did you send the child for counseling? Because these children need counseling, otherwise they'll have periodic foreign body ingestion. Was there any family history of familial disharmony? Were all these ruled out?
Yes, ma'am. There is no history of pica, and the child was counseled before the discharge.
There was no familial disharmony. The child was otherwise okay, ma'am. There was no family history also.
Now the case is
this
open.
was ma'am, this was an interesting case as magnetic injections are becoming more common in children. Each and every pediatrician should know about how to manage this case. So I would like to invite Dr. Kirtivasan sir, our pediatric gastroenterologist, to give us an insight of how he managed and how challenging it was for him. Over to Kirtivasan sir.
A very good afternoon to all. I am Dr. Kirtivasan, consultant pediatric gastroenterologist. I first of all thank Dr. Rajeshwari and Dr. Savita ma'am for giving me this opportunity to share a very vital information. So as we can see, this child had presented with multiple magnet ingestion. So multiple magnets can lead to complications like at any stage of their ingestion. So even in there are case reports of aortoesophageal fistula, case reports of perforation and peritonitis. So these children require early and prompt management. So despite their NPO status, whenever we see multiple magnet ingestion, it always becomes an emergency. First of all, when this child was admitted and when I got a call, I was away from the hospital, so immediately I had to come and address to the issue. So as we can see, the stomach was full of food in this child, and it was very difficult for me to remove without any visualization of magnets. So once I was able to visualize the magnets, it was very easy. I was able to remove it in a single attempt. uh, Magnets, even single magnets, can be we have to consider removal, because these children might be prone for subsequent ingestion of foreign bodies. And a single circular foreign body in a child who is younger than 3 or 5 years, in whom the magnet diameter is more than 2 centimeters, it is unlikely to pass beyond stomach. So in these cases where even a single magnet is there, we should consider removal, because of the fact that these children are prone for subsequent foreign body ingestion, and which can lead to life-threatening complications. So I vividly remember a case during my residency in BGI. We had seen a case of pneumoperitoneum. So we were called for two distinct foreign bodies. These are neodymium small spherical foreign bodies. So the child straight away came with perforation peritonitis. So the child was taken for elective laparotomy, and then the foreign body was removed. So these are certain points which we wanted to highlight in this case. That's it. If there are some queries, I'd be interested to answer.
Actually, it was well presented. Also, the final explanation it was elaborate actually. So it was good take-home points for all the postgraduates, that we should be very careful with magnet injection, and make sure that facilities for endoscopy as well as pediatric surgeons should be there. And also the guideline was also well elaborated, how frequently we have to follow up with the X-rays. So good presentation, Dr. Vignesh.
Thank you, sir.
Thank you.
Now we come to the end of the session. I thank all the presenters as well as the faculties who have guided these presenters for making this an interesting and very good academic feast. Thank you. Balaji, any comments?
Ma'am, first I'd like to thank Dr. Sundari ma'am for accepting to chair this session and taking. So we are happy, ma'am. And almost 50 logins were there. Plus each center, we have almost 20 plus in each center. So it's very happy to see. So on behalf of IAP, I would like to thank Dr. Sundari ma'am and Balaji Medical College, and presentations from all the three departments, Balaji Medical, Chettinad, faculties from and Kamakshi Medical College. Thank you all. Thank you faculties and students. Let's meet every month and share, because the cutaneous larva migrants we don't see in our setup. So these are all good learnings as well as good learnings for the postgraduates. Thank you, ma'am. Thank you.
Thank you.
There is a question, ma'am. I think the comments section. button battery should be removed within 4 hours or 2 hours if ingestion?
Button batteries, to answer this query, button batteries, it is important to see where is the button battery. And if there is an esophageal impacted button battery, it has to be removed emergently. So the more you delay the removal of a button battery, it will lead to higher the degree of complications, because it's a focal alkaline injury, and the injury can be there even after you remove the battery. So as early as possible, an esophageal button battery has to be removed. If the child has a button battery, as we have discussed earlier, more than 20 millimeter or 2 centimeter or a coin size of a battery, and if the child is very young, less than 3 years, so it is unlikely to pass beyond stomach. So esophageal button battery remove emergently, or gastric button battery depends upon case to case. There are multiple button batteries. There is one smaller battery which is around 10 millimeter in diameter. 20 millimeter diameter, 20 millimeter button batteries are the ones which will lead to complications. So that probably will explain his answer. So there is no time limit. If an esophageal button battery, it has to be removed immediately, as early as possible.
Thank you, sir. Thank you very much. Thank you.
Thank you.
Thank you all for your time and participation. We will meet up in the next meeting.